Hello, everyone. Today we're going to be talking about trauma-related disorders. Um, so, all right. So the disorders we're going to be talking about today include reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, and acute stress disorder. So obviously, as you've learned by now, the DSM kind of moves from the earlier developmental stages to adulthood. So reactive attachment disorder is a rare but serious condition that can be present with infants or young children when they don't establish healthy attachments with their parents or caregivers. And it may develop if the child's basic needs for comfort, affection, and nurturing aren't met, and loving, caring, stable attachments with others are not established. So maybe if they've been in chaotic environments or unstable home, maybe foster care institutions, or with parents that are abusive or just don't know how to be nurturing caregivers, this can occur. And it can also impact relationships with caregivers or persist into relationship issues throughout the lifespan. So if the child doesn't get the nurturing that he or she needs when it's tiny, and it can make the bonds a little more strained in early childhood. But with treatment, children with this disorder may develop more stable and healthy relationships with caregivers and others. So treatment for reactive attachment disorder includes counseling, parent or caregiver counseling, and education, and learning positive child and caregiver interactions and creating a stable, nurturing environment. The DSM-5 criteria includes a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers, manifested by both of the following. The child rarely or minimally seeks comfort when distressed. The child rarely or minimally responds to comfort when distressed. So it won't seek, the child won't cry. The child won't seek out help. Or the child will continue to cry and not respond, which can make the bond between caregiver and child more challenging. And it's a persistent social or emotional disturbance characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, episodes of unexplained irritability, sadness, or fearfulness that are evident during even non-threatening interactions with caregivers. The child has experienced a pattern of extremes of insufficient care, which is what typically causes this. So social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caring adults. So I've seen certain adults that maybe just aren't very educated not pick up a baby that's crying because they say, I don't want to spoil the baby. But really that's, the baby's asking for its emotional needs to be met. And so if they aren't met, then the parent, then the child may go on to have an attachment disorder. So repeated changes of primary caregivers that limit opportunities to form stable attachments, maybe frequent changes in foster care, or rearing in unusual settings that severely limit opportunities to form selective attachments. The care in criterion C is presumed to be responsible for the disturbed behavior in criterion A. Example, the disturbances in criterion A began following the lack of adequate care in criterion C. So the criteria are not met for an autism spectrum disorder. The disturbance is evident before age 5. The child has a developmental age of at least 9 months. And you're going to specify if it's persistent and the disorder has been present for more than 12 months, or current severity. So reactive attachment disorder is specified as severe when a child exhibits all symptoms of the disorder, with each symptom manifesting at high levels. So how are we going to help? The earlier the better. Working with caregivers to create stability, consistency, and trust. Teaching them how to meet basic needs if they don't understand how to do so. One-on-one play between the caregivers and child. like teaching patience and maybe controlling expectations on the part of the caregivers, particularly if a child's been in maybe a home where they were neglected and then they're with a foster parent or another caregiver. You want to help them understand kind of what's going on and how to manage their expectations. And you would want to help the child meet basic needs like control, etc. Children with DSED are not afraid of, okay, so we're moving on. Sorry, I'm a little tired, so give me a minute here. Okay. Disinhibited social engagement disorder is basically the opposite of reactive attachment disorder. So children with DSED are not afraid of adult or strangers, and they're not shy of meeting new people for the first time. Instead, they're overly friendly, overly talkative to strangers, and may even begin hugging or cuddling unknown adults. They show no fear when a stranger talks to them or touches them. And they may not hesitate to take off with an unfamiliar person and will not look to parents or primary caregivers to approach strangers. So most kids have kind of a built-in safety system. They feel a little shy or a little fearful around adults, but children with disinhibited social engagement disorder don't have that at all. They don't have that mechanism. And so the DSED symptoms may continue into teenage years, but the condition is not known to last into adulthood. So disinhibited social disorder, the criteria includes a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least two of the following: reduced or absent reticence in approaching and interacting with unfamiliar adults, overly familiar verbal or physical behavior that's not consistent with culturally sanctioned and age-appropriate social boundaries, diminished or absent checking back with adult caregiver after venturing away, even in unfamiliar settings. They're willing to go off with an unfamiliar adult with little or no hesitation. So the behaviors and criteria in A are not limited to impulsivity, as in ADHD, but include socially disinhibited behavior. So kids may be a little impulsive, but they're not expressing these total social disinhibitions. The child has exhibited a pattern of extremes of insufficient care, as evidenced by at least one of the following: social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults, repeated changes of primary caregivers that limit ability to form stable attachments, rearing in unusual settings that severely limit opportunities to form selective attachments. The care in criterion C is presumed to be responsible for the disturbed behavior in criterion A. The child has a developmental age of 9 months, and the disorder has been present for more than 12 months. And you want to specify severity. And it's considered severe when a child exhibits all symptoms of the disorder, with each symptom manifesting at relatively high levels. Treatment for DSED: increased bond with caregivers, art and expressive therapies, safety planning, because obviously we want to teach children that it's actually not okay to go off with strangers, to jump in strangers' laps, to cuddle people they don't know. We want to teach them those basic safety skills. And as a side note, research is now questioning whether this is actually an attachment disorder. It may be related to something else, and it's not known to persist into adulthood. So hopefully they'll grow out of it, but we need to keep them safe until they do. Post-traumatic stress disorder. So moving right along. So we know, we've all heard of PTSD in soldiers, and we know that it's an extreme response to a severe stressor. They've been impacted by something major in their life, a trauma. They've seen a death. They've been in a near-death situation. They've been raped or traumatized in that way, sexually, or they've been severely hurt in some way. So some of the symptoms that they experience are anxiety, avoidance of stimuli associated with the trauma, and emotional numbing. And exposure to a traumatic event that involves actual or threatened death or injury, as mentioned before. So, for example, they might have been in war, they may have been raped, they may have experienced a natural disaster. And trauma leads to intense fear or helplessness, and the symptoms present for more than a month. And for women, rape is the most common type of trauma. So the criteria for PTSD is it's clustered into 4 categories of symptoms, which includes intrusively re-experiencing the traumatic event through nightmares, intrusive thoughts, or images. There's an avoidance of stimuli, so refusing to walk on the street where the rape occurred, or avoiding parts of town, avoiding cars that remind them of what happened, avoiding, people who look a certain way. And then there are other signs of mood and cognitive changes, such as memory loss. Memory loss is very common for people that have experienced a trauma. Negative thoughts and emotions, self-blame, blaming others, and withdrawal. Increased arousal and activity, so irritability, aggressiveness, recklessness, or self-destructiveness. Insomnia, difficulty concentrating, hypervigilance, and exaggerated startle response can occur. And it tends to be chronic, with a higher risk of suicide and self-injuries and illness. So common risk factors, the etiology of PTSD includes common risk factors with other anxiety disorders. There's a genetic overactive amygdala, childhood exposure to trauma, or adulthood exposure to trauma, selective attention, neuroticism, and negative affectivity. There's a 2-factor model of conditioning also applicable. Unique factors include severity and type of trauma. There are biological issues at play, like a smaller hippocampal volume linked to PTSD, and avoidance, coping, disassociation, and memory suppression. So intelligence, social support, and the ability to grow from the experience enhance coping. So this is the criteria. Person was exposed to death or threatened death, so they've experienced a horrible situation. They're having at least one of the following intrusion symptoms, including involuntary and intrusive memories of the trauma, or repetitive play regarding trauma themes, recurrent distressing dreams related to the events, dissociative reactions, for example, flashbacks or spacing out and blacking out, in which the individual feels or acts as if the traumas were reoccurring, and intense or prolonged distress or physiological reactivity in response to the reminders, and at least one of the following avoidance symptoms. So avoiding internal reminders, thoughts, feelings, and physical sensations that arouse recollections of the trauma, or avoiding external reminders, people, places, conversations, activities, objects, situations that arouse recollections of the trauma. Psychological treatment of PTSD includes exposure to memories and reminders of the original trauma. So basically, you're doing exposure therapy with a trusted therapist. So you've got your coping skills, your grounding methods, you really trust this person and you feel safe. And then you're allowing yourself to either imagine or in life experience a reminder. And there's also virtual reality sometimes. They've done this a lot with war veterans. They use VR to kind of simulate the environment to help someone decrease the physiological response, work through the feelings in the moment to try to neutralize that stimuli. And treatment can be difficult at first, and there's a possible increase in symptomology, like right when you start talking about it. Cognitive therapy can help. It enhances beliefs about coping abilities. Adding cognitive therapy to exposure does not improve treatment response, and treatment of ASD may prevent PTSD. Okay. So we mentioned treatment of ASD. That is acute stress disorder. So acute stress disorder is like the precursor to post-traumatic stress disorder. with similar symptoms to PTSD, but with a shorter duration of time. And the symptoms occur between 3 days and a month after the trauma. And disassociation does not necessarily have to be a symptom. And as many as 90% of rape victims experienced ASD. And ASD predicts higher risk of PTSD within 2 years, but if you treat the ASD, there's less of a likelihood of getting PTSD within 2 years. So that's all I have for you tonight. Thank you for listening to my rant about trauma-related disorders, and I hope you have a wonderful evening or day. I don't know what time it is when you're watching this, but have a good one.